Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're delving into transcatheter aortic valve implantation, commonly referred to as TAVI. Specifically, we'll be exploring the nuances of treatment for female patients with aortic stenosis and the pivotal role choice plays in their health outcomes. We're aware that various patient groups present with small annuli, for example with patients of Asian descent being more predisposed to having a smaller aortic annulus, and in instances where a valve-in-valve procedure is required. However, notably, up to 90% of the small annulus population comprises women. The SMART trial, the largest TAVI RCT primarily enrolling women, that explores the differences in patient outcomes with valve choice, addresses the research gap for this underrepresented group. This podcast is made possible by Medtronic, however the views expressed here are not necessarily those of Medtronic. To delve deeper into this topic, the interview will be conducted by cardiologist Doctor Camilla Wainwright from St Vincent's Private Hospital. And to discuss the latest data and its implications for female patients with aortic stenosis, we're joined by interventional cardiologist Dr David Roy from St Vincent's Hospital.
Well, it's lovely to talk to you about something, a topic that's very important, David.
This is obviously something that's very close to my heart, having spent the last 10 years thinking about and talking about and being involved in TAVI procedures. And it's great to see that we've sort of, I suppose, finally got a proper quality randomized trial that's actually, I guess, angled towards women, which is something that we haven't often seen in cardiovascular trials, if we're honest, over a long period of time.
Yeah. So I guess in if we're talking in that sense, how do you think aortic stenosis does differ in our female patients? And so what should we be considering for treatment, or what are the treatment considerations in females particularly?
I think we see that the most obvious thing is women have smaller anatomy. They have smaller annulus dimensions, and that has a lot of other effects. Of course, smaller anatomy means less room for coronary flow, less room to actually fit devices into, and potentially less options for redoing a transcatheter procedure in the future were the first valve to fail. It's very well established that women with severe AS have less aortic valve calcium compared with men, even after we index for body surface area or annulus area. And it's not entirely understood as to why that is. There may be sex-specific hormonal differences which could explain why men develop more calcific aortic valve disease than women. However, it still remains unclear why women develop more hemodynamically severe AS at a lower degree of aortic valve calcification. And visually, when we're doing CT scans for women with severe AS, we will often see more fibrous or fibrocalcific disease with thickened leaflets rather than just pure calcific aortic stenosis. But I think we don't yet completely understand why that is. Women with severe AS more often have diabetes, hypertension, chronic lung disease, as opposed to men who tend to have more coronary artery disease and peripheral arterial disease. And at presentation, women with severe AS are often older and have a greater symptom burden. And we do see women more often presenting with dizziness rather than presenting with, I guess, the typical symptoms of breathlessness or chest pain.
Do you think that's perhaps why they present a little bit later, that they sort of minimize the symptoms a little bit until they're really well established?
Yes, I do. And I suppose that comes back to almost every cardiovascular condition that we treat, in that women are unfortunately
Late presenters.
late presenters and undertreated. And when we think of heart disease, we often think of the overweight middle-aged diabetic man, and the thin, well-looking woman sitting beside him may actually have worse disease, but it's not always appreciated. I think the other important thing about women with aortic stenosis is, of course, because they're not um, being, I guess, identified as having their condition, they're not being treated as early as men, and often when we are treating them, their disease is worse, and sometimes that means their left ventricular function is worse, and the severity of their aortic valve disease is worse, which of course can make the procedures themselves, potentially more risky.
Mm-hmm. Okay, thank you. So you mentioned about treatment options then. Let's talk about some of the treatment options for aortic stenosis. And we know about transcatheter aortic valve implantation, that's been evolving since, I guess, the first case in approximately 2002. We know that it's a well-established treatment option for aortic stenosis. I understand, and you alluded to it earlier, that at the ACC recently, the SMART trial was presented, and it was looking at the safety and efficacy of two commonly used TAVI valves in patients with a small annular size. Can you explain a little bit about why this trial is so important?
Yeah, I mean, this trial really is a landmark trial because it looks at two specific novel things. One of them is it's really the first trial which is looking at predominantly female patients. Approximately 90% of the patients in this trial were female. Um, and patients with small anatomy represent about 40% of all TAVI procedures being performed worldwide. So it is an important group of patients to think about. The second point really is that this trial is the first randomized, properly rigorously controlled trial to look and compare two of the commonly used TAVI devices. And previously, the data we've been using to compare devices has been registry data, or it's been comparisons of randomized trials done of these individual valves done versus surgery. So this is actually unique in that we're comparing the valves themselves.
Mm-hmm. And what were the outcomes or the main objectives and main outcomes of this particular trial?
So the first co-primary outcome, I guess firstly to say that actually there's 716 patients enrolled. The duration of follow-up was 12 months, so it's a relatively short follow-up period. Average age of patients is 80 years, which is very standard for a TAVI trial. The first co-primary endpoint looked at death, stroke, or heart failure hospitalisation, and there was a numerically lower 9.4% primary outcome in the self-expanding group, 10.6 in the balloon expanding group, but really the p-value was not significant, and it did meet criteria for non-inferiority of the self-expanding valve. But I don't think that's probably where the interest in this trial lies. The second co-primary endpoint looked at bioprosthetic valve dysfunction.
Mm-hmm.
Bioprosthetic valve dysfunction was defined as a mean gradient greater than 20 millimeters of mercury, either with severe patient prosthesis mismatch or greater than or equal to moderate aortic regurgitation, aortic thrombosis, endocarditis, or reintervention at 12 months. And there was a very significant difference between the two valve platforms for this second co-primary endpoint. And in the self-expanding group, the second co-primary endpoint was met in 9.4% of patients, whereas it was 41% of patients in the balloon expandable group. So this is a very great difference indeed. To go into that in a little bit more detail, because the wording bioprosthetic valve dysfunction might lead one to think that we're talking about the valve actually deteriorating over that 12 months, whereas that's not really what's going on. What we're actually describing is that the original balloon expandable valve implanted has a higher gradient. That means, obviously there's more velocity going through those leaflets, which in turn may lead to earlier failure. And that's certainly something we think about when we think about even native valves. The higher the velocity, the greater the likelihood that the valves may fail over time.
Mm-hmm. It sounds like bioprosthetic valve dysfunction is obviously very important. At what stage do you typically see it occurring?
Well, I guess it's a very good point, and this is sort of moving goalposts in some ways. In that, if we look back to our surgical literature, bioprosthetic valve dysfunction was defined as freedom from re-intervention, so freedom from doing another operation.
Hmm.
Which, if a patient is not well enough to have another operation, that's clearly not a good way to measure it. So we need some echo-based parameters to really be able to follow these patients. And so the Valve Academic Research Consortium, or the group called VARC, came up with a definition which includes patient prosthesis mismatch, and of course it's also gradient based. But usually we would expect bioprosthetic valve dysfunction in terms of actual structural valve dysfunction to occur, beyond 5 years, not that early.
Hmm.
Whereas if we implant a valve and the immediate gradients are very high, we have to have some parameters to say, look, this wasn't the ideal outcome, particularly in a small anatomy where a second valve may not be possible.
So, if we're thinking about the SMART data, then do you think that the results actually impact who we select and the treatment options for female patients in particular?
Yeah, absolutely. I think when we're thinking about treating patients with bioprosthetic valves, we have to think about the lifetime of the patient, and really, in all cases, we're trying to minimize the number of operations the patient will have. If we're talking about treating very young patients, obviously surgery is still a very important consideration, because we can't keep placing another valve inside another valve indefinitely. The Russian doll effect will mean that orifice gets smaller and smaller.
Hmm.
But we are trying to minimize the total number of procedures for patients, and also ensure that if they need a second procedure, that's possible to do in a transcatheter manner and possible to do safely. And so this really impacts patients with smaller anatomy, because in many circumstances it's actually not possible to put in a second valve due to the risk of coronary obstruction from the anatomy. And so it's really important that the original valve is actually got good hemodynamic performance and a much lower risk of actually structural valve deterioration.
And gives them longevity. Mhm.
Yeah, absolutely.
Okay. So it sounds like we should be thinking differently about our female patients. Do you think we as cardiologists do need to treat them differently and think about our female patients with the aortic stenosis somewhat differently based on these results?
Yeah, very much so. And there's so many points to that question. I suppose when we think about you know consideration of following patients with their symptoms, we've for many years we've been seeing patients with severe AS and saying you're asymptomatic, and I think we all underuse the stress test as a way to really get some objective information as to whether the patient is truly asymptomatic or not.
Mm. Or just
I
not
think,
pushing themselves and not.
yeah, and not pushing themselves. And
Mm,
I think when we're using CT imaging and when we're using calcium scores on valves, we have to be mindful that um, in women that data may not be as accurate, particularly if we're using that calcium score where the ventricle might be impaired, and we're trying to make a sensible decision as to why the valve area is low, and where a calcium score that's lower may still represent severe aortic stenosis.
mhm. And so functional testing obviously might be pretty relevant and important for these patients as well, and following them closely even without symptoms.
Absolutely. And I think also, even coming back a step, having a higher index of suspicion in women to, for patients saying, even in the primary care setting, that they're not, feeling typical symptoms of breathlessness or chest pain, but might be feeling lethargy or even, as we mentioned, lightheaded,
Mm,
then they should be sent for an echo, because I still think our screening for women is not up to what it is for men.
mhm. Well, thank you. That was fascinating. I really found that useful, and thank you for expanding on the data and information from the SMART trial. It sounds like, whilst there's a little way to go, that's very informative.
Yeah. Thanks so much, Camilla.
Thank you.
Thanks.
Thank you to my special guests, Dr. Camilla Wainwright and Dr. David Roy. This podcast is made possible by Medtronic. However, the views expressed here are not necessarily those of Medtronic. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.